Greetings, everybody. Dr. Shah will be here momentarily. Victor Perez is here.
Hello, John.
Hey, Victor, how you doing?
How are you?
Good.
Very
Good.
nice.
I
Now,
I
another
couldn't.
another
I tried to
another
get.
neuroanatomical day.
Yeah, that's right. Today is Neuroanatomy Day. Yeah, yeah. We'll have to celebrate it. Celebrate it every
Yeah,
Monday.
that's good.
Every Monday, Neurosurgery Day.
Yeah.
So how you been?
Very fine. Very good, very good.
You working out? These times don't affect me that much. I just work at the computer, so it's no difference for me. Is it much difference for you? Do you go to the
No,
hospital every day or no?
no.
No. You work at your own schedule, right?
Yeah.
Yeah, so that makes it more convenient. And I almost like the quiet. It is quiet here in Miami Beach. Okay, Dr. Shah, are you here?
Why? Why? Because of COVID disease or why?
Yeah, that's why. It's real quiet. There's no tourists here. Hello, Dr. Shah. Good morning.
Hi, John.
How
Hi,
you
Dr.
doing?
Shah. I'm fine.
Good.
Yeah.
Good. I don't know if I'll be able to get those Kahoot questions because they're kind of long. They can't take long questions.
Okay.
So maybe I'll try to throw something together if I can do it.
Okay.
But we'll prepare better next time.
Yeah.
It was kind of a last minute thing.
Yeah.
So we'll hang around your studio for a couple minutes after.
Okay.
I don't know. Who
Hello,
knows?
David. How are you?
We'll try it. Why not?
Hello, Dr.
Hello,
Victor.
David. Hello.
I'm good. How are you?
Fine. How are things in Mumbai?
They're little better. Little better.
How about COVID disease in
Yeah.
Mexico? Is a
Is it getting
problem, no?
worse? Getting worse or better?
No, it's little
Maybe.
better.
Yeah. Yeah, Miami's the same. It's
Yeah.
actually getting more restrictive now.
Yeah.
They're getting stricter and they're closing things again,
Okay.
like restaurants and stuff. Same in Mumbai?
No. We are opening.
Okay.
But I guess again, maybe there will be a second wave and then we don't know what's going to happen.
Yeah, that's what there was here,
Yeah.
beginning of a second wave, so they're trying to anticipate it. So,
Yeah.
Abid,
Yeah.
Abid, but COVID is not problem for you. You are very young. So the problem is for us.
that's right, the older people. Move over in the cemetery. I'm not ready for the cemetery yet, Victor. I don't think so. It's too early. There's too much fun on the computer.
Yeah.
That makes, I'll tell you, I was born again when the computer was starting to be used.
You're really enjoying this, huh, John?
What's that?
You're really enjoying this.
Oh, yeah. Are you
Yeah.
kidding? It's the
Yeah.
best time of my career.
Yeah.
Best time. I think if I was a student, I would be glued to the computer, I think.
Yeah.
But now it gives me a chance to still participate, and be
Mhm.
active. So, okay, you ready to start?
Yeah.
Okay, lateral. Let me get the title right. Okay, we'll start. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neuroanatomy.tv. We have the pleasure here of having Abhi Shah, a neurosurgeon from Mumbai, and a well-known neuroanatomist who's done a couple of lectures in this series, and she's going to do another one today. Let me introduce Victor as panelist first before I turn over to Abhi. Hello, Victor. Welcome.
Hello, John.
You
Here,
always introduce, it's like
we are
Ed
ready.
Sullivan. You introduce celebrities in the crowd.
Yeah, we are ready to listen a wonderful lecture of anatomy with Abhi from Mumbai.
Okay,
He
very good.
really,
Okay,
really good lecture last time. So now I think that it is going to be the same. Wonderful.
very good. Okay, Abhi, it's all yours.
Okay. Here we go. Okay. Can you see my screen?
Yes,
Okay.
yes, perfect.
Okay. So now we move on to the more inner aspect of the brain, where we are covering the lateral and the third ventricles, and the anatomy and the approaches to the lateral and the third ventricle. So basically, the lateral and the third ventricle are in the innermost aspect of our hemispheres, and approach to these regions is very difficult because you have to cross many neural structures and fibers to reach the ventricles. So we have to find adequate areas and decide adequate approaches which causing least damage to the ventricular structures and approach tumors in this region. So basically, this is the promesencephalon, the forebrain. So what happens when the forebrain develops a transverse fissure? It divides it into a telencephalon and a diencephalon. So the lateral ventricle is the cavity of the forebrain, and the third ventricle is the cavity of the diencephalon. So when this invaginates, this area, invaginating in the area of the interhemispheric fissure, it turns inside and forms the anterior wall. It kind of dips inside. So the anterior wall is known as the lamina terminalis, and it forms the anterior wall of the third ventricle. So the anterior wall of the third ventricle is basically a telencephalic structure, and the third ventricle and its surrounding are diencephalic structures. So this is how it is when embryologically when the development starts, and this is how the ventricles look in the newborn. And you can see the various parts of the ventricle here. You have the lateral ventricle, you have the body, you have the occipital horn, the atrium, and the temporal horn, going into the third ventricle, which is then going into the aqueduct and the fourth ventricle. So why does the ventricle have a peculiar C shape? This is your region of the thalamus. So when your cerebrum folds, it folds around the thalamus just like all your limbic structures, and you have a C-shaped ring that forms around the thalamus. That is your lateral ventricle. And the cavity which runs between the thalami is your third ventricle. So basically, your thalamus sits as a head on your brain stem, and the cerebral hemisphere forms around it along with the lateral ventricle, giving it its C shape. Another peculiar thing about the ventricle is it is completely enveloped by fibers of the corpus callosum. So you see this MRI image here. You can see that this is the region of the corpus callosum. This is your internal capsule. So your whole ventricular system is enveloped within the fibers of the corpus callosum. So the corpus callosum has dorsal radiations and ventral radiation. So your corpus callosum is basically enclosed within the ventral callosal radiations, and even the atrium and the temporal horn is surrounded by tapetum, which is an extension of the ventral callosal region radiation as it moves laterally. So you have the whole ventricle, it is surrounded by fibers of the corpus callosum. So this is another image where you can see that this is the corpus callosum, which is having dorsal radiation and ventral radiations, and the whole ventricular cavity is within this corpus callosal fibers. So since the ventricle is in the innermost aspect of the brain, we have to design specific operative strategies to reach its core. So there are many avenues that are available, and we will discuss each one of these. So basically you have the anterior transcortical. These are the major ones: the anterior transcallosal, the posterior transcallosal, the posterior transcortical, the occipital transtentorial, the supracerebellar infratentorial. Then you have an approach that we have designed, that is the orbital cortical approach. I will discuss this. And then you have approaches to the anterior part of the third ventricle through the lamina terminalis. And then of course you have frontotemporal and subtemporal approaches. So this majestic structure that you see here is the lateral ventricle and the third ventricle. So the lateral ventricle is surrounded by the corpus callosum, as we have seen. So you have the rostrum, you have the genu, you have the body and the splenium of the corpus callosum. This structure here is the fornix. So the lower part of the corpus callosum and the upper part of the fornix are connected to each other by a thin membrane, that is your septum pellucidum, which forms the medial wall of both the frontal horn and the body of the lateral ventricle. The third ventricle I will discuss later as we go on further. So going to the region of the lateral ventricle, again you can see the rostrum, the genu, the body and the splenium of the corpus callosum. This is the fornix. This is the septum pellucidum. Now the septum pellucidum narrows down in this region where the fornix and the corpus callosum come close to each other. This is in the region of the crura of the fornix, where they almost touch the splenium in the region of the hippocampal commissure. So in this region, your septum pellucidum disappears. And inwardly, this marks the boundary between the body of the lateral ventricle and the atrium of the lateral ventricle. So your body of the lateral ventricle extends from the foramen of Monro all the way to where the septum pellucidum ends, and the region of the ventricle in front of the foramen of Monro is your frontal horn. So what happens when you remove the septum pellucidum? You remove this thin layer, and now you can see beautifully the lateral wall of the lateral ventricle, frontal horn of the lateral ventricle, and this is your caudate nucleus. This is the region of your fornix. This is the region of your anterior commissure. The fornix are coming down here as the columns of the fornix to end in the mammillary body. Now the corpus callosum has been cut transversely. So the roof of the ventricle has been removed. So mind you, the roof of the frontal horn, as you can see here, the roof of the frontal horn, the body and the atrium is all part of the corpus callosum. So you have the genu, you have the body and the splenium. So now I have cut the roof here, and now you can see the floor of the lateral ventricle completely. So this region is your frontal horn. You have the caudate head here, and then the body of the caudate as it turns around here. So this is the floor, lateral wall of the frontal horn and the body of the lateral ventricle. This is the region of your thalamus, and this is your atrium, which we will see in the next image. So this is the view from the top, a superior view where the corpus callosum has been removed. You can see the caudate nucleus quite beautifully. This is the thalamus. This region here is your striothalamic sulcus. In that, we have two structures that run. You have the stria terminalis and you have the thalamostriate vein. The stria terminalis basically runs from the region of the thalamus here all the way down to the amygdala, and it forms part of the dorsal amygdalofugal pathway that we had seen last time. So here you have the floor of the lateral ventricle, floor of the body of the ventricle, which is formed by the thalamus. The medial wall, as we saw, was formed by the septum pellucidum. The lateral wall is formed by the caudate nucleus. And moving further downwards, when you go in the region of the atrium, you see the fibers of the splenium as they turn laterally to connect the occipital lobes. And you can see this is the region of the forceps major. They form a prominence in the medial wall of the atrium that is known as the bulb. Just below it in the atrium is another prominence that is formed by the calcarine sulcus, and that is known as the calcar avis. So the medial wall of the atrium has two bulbs, has two prominences, the bulb, which is formed by the forceps major, and the calcar avis, which is formed by the calcarine sulcus. Here, this region is your choroid plexus. So basically, your choroid plexus forms a big tuft in the region of the atrium, and that is called the glomus of the choroid plexus. So again, this is a view of the ventricle that you can see completely here now. This is the corpus callosum. This is the caudate nucleus. This is your fornix. As it is coming down into the temporal horn, this is the region of your hippocampus. So your fimbria are forming here on the hippocampus and turning all the way and going up and forming the fornix, the crura and the body and the columns of the fornix. In this region you see here, so basically the lower part of the ventricle is completely related to the circle of Willis, the lower part of the third ventricle. Here you can see the anterior choroidal artery as it enters the choroidal fissure at the inferior choroidal point. So the inferior choroidal point marks your junction between the head of the hippocampus and the body of the hippocampus. And this is where it enters the choroidal fissure. So this is one of the main supplies of the vascular supply of the ventricle. And posteriorly, you have the medial posterior choroidal artery, which enters from the roof of the third ventricle, as we saw in Dr. Victor's presentation last time. And then laterally, you have the lateral posterior choroidal artery that enters into the atrium of the ventricle. So here you can see the lateral posterior choroidal artery. Anteriorly, you will have the medial posterior choroidal artery going into the roof, and inferiorly, you have the anterior choroidal artery as it enters the temporal horn. So what are your external landmarks for the ventricle? So for your frontal horn, it lies deep to the pars triangularis and to the pars opercularis. So the opercula have been removed here, but this is your region. So the frontal horn will lie basically deep to the pars triangularis and the pars opercularis. The body of the lateral ventricle lies deep to the inferior portion of your precentral gyrus and your postcentral gyrus. So this is your central sulcus, precentral and postcentral gyrus. So this is the landmark for the body of the ventricle. The atrium of the ventricle lies deep to the supramarginal and the angular gyrus in this region. And also it is covered by parts of the superior and middle temporal gyri, which have been removed here. And the temporal horn lies deep to the middle temporal gyrus. So these are your cortical landmarks when you come from laterally to approach the lateral ventricle. When you go deeper, you have some other landmarks which will help you lead you to the ventricle. So this is your insular region. So your frontal horn of the lateral ventricle is related basically to your middle and posterior short insular gyri. As you can see here, this is the middle and the posterior short insular gyri, and this is related to the frontal horn. The posterior portion of the posterior short gyri and the long gyri are related to the body of the lateral ventricle. Then you have the anterior insular point, which points to the caudate nucleus, and you have the posterior insular point, which points to the atrium of the ventricle, as you can see here very clearly. So here you have the corpus callosum, you have the fornix, inside you have the caudate head, and you can see the various relation. And this is the choroidal fissure. We will see it in more detail later. So we've seen the cortical landmarks to approach the lateral ventricle. Now we'll see the fibers that come in the way when you're coming in the region of the lateral ventricle. So this is your lateral perspective. So you can I've superimposed the image of the lateral ventricle on the fiber tracks. So this is your corona radiata. This is your superior longitudinal fasciculus part 2 and part 3, or the lateral SLF. And this is your arcuate fasciculus. So the arcuate fasciculus runs as a C along the inner margin of the ventricle, and to approach the ventricle laterally, you would have to cross the SLF and the arcuate to reach it, and the corona radiata. So this is not the traditional approach that we go through to reach the lateral ventricle. When you come from medially, so medially, if you're coming transcortical, you will go through the medial part of the SLF and the cingulum. So this is the fibers that you will cross if you're approaching the ventricle from medially. And if you come interhemispheric, you do not cross any of these boundaries, and you will straight encounter the corpus callosum, where you can make a small callosotomy and enter the ventricle. So this is an MRI image depicting the various fibers in relation to the ventricle. Here you have the cingulum, here you have the corpus callosum. Further below, in the region of the caudate head and the floor of the frontal horn, you'll have the inferior fibers, the frontal fibers of the IFOF, the inferior fronto-occipital fasciculus, and posteriorly, lateral to the temporal horn, you'll have the temporal extension of the inferior fronto-occipital fasciculus. And in the region of the Lyman insulae, you'll have the IFOF, which is narrowing down, and the uncinate fasciculus, which is going from frontal to temporal. So this is from a lateral perspective. And when you see an axial cut, here you can see the fibers of the corpus callosum. The fibers of the corpus callosum also turn anteriorly here to form forceps minor, and they will form the part of the frontal horn, anterior wall of the frontal horn. Here you have the forceps major, which are forming the, so you can see this prominence here in the region of the atrium, and this is your bulb, which is formed by the prominence of the forceps major, and you have the IFOF. Then posteriorly you have the optic radiations as they form the lateral part of the atrium, and here you have the arcuate fasciculus as it is running around the insula. And this is your region of the internal capsule, where you can see that it is very closely related to the foramen of Monro. If you injure the internal capsule in this area, you're going to end up with hemiplegia. So what about the approaches to the frontal horn and the body of the lateral ventricle? So there are two main approaches. When you want to approach the frontal horn and the body, you have a transcortical approach to the middle frontal gyrus, or you have an interhemispheric approach that goes along the falx in the interhemispheric fissure. And this is technically when you're operating and you want to operate in the region of the frontal horn, your craniotomy is classically 2/3 in front of the coronal and 1/3 behind the coronal suture. So this is your region of craniotomy. And of course, if you're going transcortical, you will go in the region of the middle frontal gyrus. So what are the fibers that come in the way? So when you come through the middle frontal gyrus, you will encounter the fibers of the superior longitudinal fasciculus, that is your lateral part of the superior longitudinal fasciculus. If you come more laterally, you will come to the arcuate fasciculus, and above all that, you will have fibers of the corona radiata. So all of these fibers will come in the way when you're going transcortical to approach the frontal horn and the body. And when you're coming from medially, if you again come, you can either directly enter in the region of the corpus callosum here, or sometimes when the brain is too tense, you can enter here in the region of the cingulum. So this is your medial perspective, where you can see the frontal horn and the caudate nucleus and the thalamus in this region. So let's look at some cases. So you can see here there is a tumor. This was a sega in the frontal horn of the lateral ventricle, and we have approached this through an interhemispheric approach. And you can see here the callosal incision, and the tumor was completely removed. This is another tumor that is occupying the body of the lateral ventricle, also extending into the frontal horn. And again, this tumor has been approached by a transcallosal approach, and you can see the tumor excision in this region. This is another intraventricular meningioma, which has again been approached by a transcallosal approach. So basically, we prefer a transcallosal approach because it has it transects the less amount of fibers as you go along the trajectory, and you just have to enter into the corpus callosum, and then you can enter the tumor. So you can see the callosotomy in this region, and the tumor has been excised. What happens when you come in the region of the atrium? So the atrium can be approached either by an interhemispheric route, by a transcortical route, or sometimes by a transtentorial route. So we prefer the transcortical route, especially for intraventricular meningiomas, as you can see here that it has been resected imminently. Now the problem with this approach on the left side is that there are a lot of fiber tracts in that region. So if you go in the wrong direction, you will have a problem of causing a Gershman syndrome with all its other dominant problems. So basically, when you want to enter for transcortical approach to the atrium, you should enter through the supramarginal gyrus, which will cause least injury to these fibers, as you can see in this image. So what are the fibers that come here as you try to approach the atrium? So you have the fibers of the arcuate fasciculus, which have been cut here. So this was your region of the atrium, as you saw here. These are the fibers of the arcuate fasciculus, which are running down here. They have been cut here. You have fibers of the inferior fronto-occipital fasciculus as it is running. You have fibers of the anterior commissure, and more medially, you have fibers of the optic radiations. And beyond the optic radiations, you will also have fibers of the tapetum, which are the ventral callosal fibers. So in the dominant region, in this junction, this is the temporoparieto-occipital junction. If you injure this area, then you are going to have a big problem. So you always try to enter from the superior parietal lobule or the supramarginal gyrus. So this is an image that is showing how the fibers are related to the temporal horn and the region of the atrium. So you can see this is the arcuate fasciculus as it is running superior to the temporal horn. And these are your fibers of the tapetum and the optic radiations as they are covering the lateral part of the atrium. Here you can see them more clearly. So this is an image that is taken from the top. Here you can, this is anterior, this is posterior. This is the atrium of the lateral ventricle. And these are your corpus callosal fibers. And you can see how these corpus callosal fibers are running over the roof of the atrium and going to the lateral wall, forming completely the roof and the lateral wall of the atrium of the ventricle. So these are the fibers that you will transect once you're entering the atrium of the ventricle. So we had a large series of meningiomas that was published by Professor Goel a long time back, and we have a good experience with these meningiomas with very good results. Now, what happens when you have tumors in the floor of the lateral ventricle? So we have seen how to approach tumors in the floor above, in the frontal horn and the body of the lateral ventricle. What happens when you have tumors absolutely at the base of the lateral ventricle, like this? So this is a region which is, this is a tumor in the region of the caudate nucleus. Just on the floor, it is arising from the caudate nucleus, which is in the floor of the frontal horn. So this is where your tumor is. So there have been approaches that have been described. So people come transcallosal, ipsilaterally. There are some people who prefer the contralateral transcallosal approach to reach the caudate nucleus. However, both these approaches have very long trajectories, and you have to incise, because of the long trajectory, and the pericallosal artery come in the way, and there are other structures that also come in the way. We have devised another approach to reach the caudate nucleus, and the approach is through the inferior aspect, as I will show you now. So this was, Professor Goel first described this approach, a contralateral approach to a contralateral hemispheric tumor by the transfalcine approach. You can see here, this was the trajectory that was taken to approach this tumor. This was, of course, a hemispheric tumor, but this, of course, same trajectory can be taken to approach the caudate nucleus. And this was another contralateral approach to a medial frontal AVM in the interhemispheric fissure. So again, you can see how long the trajectory is. It is, of course, possible, but this is a long trajectory to reach the caudate nucleus. So this was an approach that we devised by Dr. Goel again. And this is in the orbital cortical region. That is your orbital gyri. So you enter the frontal horn from the region of the orbital gyrus. What are the fibers and what are the structures in this region? So here you have this is anterior, this is posterior. This blue structure here is your lateral ventricle. This is your foramen of Monro as it is going to the third ventricle. And the green structure here is your caudate nucleus. So we are talking about approaching tumors in this region, in the region of the floor of the lateral ventricle. So what structure comes in the way is basically this, forceps minor, as it forms the anterior part of the wall of the frontal horn of the lateral ventricle. So these are the fibers that you will transect to reach this frontal horn and also the caudate nucleus. As you can see again in this image, these are the fibers of the forceps minor. So we've devised two approaches. We can either come from the middle orbital gyrus with a trajectory that is going inferiorly and laterally, or you can come from the lateral orbital gyrus with a trajectory that is going again medially and inferiorly. So these are the two approaches, and you can see this is the region of your frontal horn, and this is your caudate nucleus in the frontal horn. And this is an upturned image. So this is the corpus callosum. This is the inferior, this is the superior. This is your interhemispheric fissure. So I've turned the image. You can see the frontal horn. I want to show the relation of the forceps minor to the frontal horn. Here you can see the forceps minor that are coming in the anterior part of the frontal horn. So this is the only fiber that will be in the way of your trajectory if you're coming from a medial approach. If you're coming from laterally, so this D that you see here are the fibers of the IFOF as they're running laterally. But of course, if you are a bit superior to those fibers, you can completely avoid injury to this and straight enter the frontal horn in this region. So this we have found it to be a safe approach with a short trajectory for lesions in the region of the caudate nucleus. And this is how the fibers of the IFOF run from the frontal part of the hemisphere to the temporal part. And just beneath here in the region of the Lyman insulae, they are in front of the IFOF, you have the uncinate fasciculus. So suppose this is your lesion. This is your lesion in the caudate nucleus. And we use this approach. You can see this is the shortest approach to this region. So through the orbital gyri. So you take the head in extension and you can straight enter from the orbital gyri. And this is the fibers that are in relation to this deep tractography. And you can see the trajectory that we have taken with a complete excision of the tumor. This is another tumor that is in the region of the caudate head. Again, we have approached through a orbital cortical approach, and you can see the tumor resection, which is quite radical. Also for arteriovenous malformations. So this is a case, the patient who presented with us, intraventricular hemorrhage, and this was the CT scan. And this is the angiogram, CT angiogram and the DSA. It showed a small AVM, arteriovenous malformation, in the region of the lateral aspect of the frontal horn. So again, an orbital cortical approach was used by us to approach this region. And you can see the post-operative image showing resection of the arteriovenous malformation. So now we have seen the frontal horn, the body, and the atrium of the lateral ventricle. Now let's come to this other important structure, that is the foramen of Monro. So the foramen of Monro is a small cavity that connects your lateral ventricle to your third ventricle. It is bordered by the columns of the fornix, as you can see here, as they are turning here. The fornix is turning here into the columns. So it is the anterior inferior body, part of the boundary of the foramen of Monro, and its posterior boundary is your anterior aspect of the thalamus. So here you can see the cavity, and you can see that the choroid plexus completely enters into the cavity to enter into the third ventricle. So this is a closer view. Here you can see the various relations. This is the anterior commissure. This is the column of the fornix. This is your foramen of Monro as it is entering the third ventricle, and this is the choroid plexus. So this is an axial cut section where you can see completely the course of the choroid plexus as it is going here into the interventricular foramen of Monro, and all the way coursing to the atrium where it is forming a glomus and then running down below in the region of the temporal horn. And the structures that you can see here in this cut section are, here you can see the thalamus, here you can see the caudate nucleus, and this is your region of the lentiform nucleus. Now you can see that the internal capsule comes in this region. So this is your foramen of Monro, and this is where your genu of the internal capsule makes contact with your ventricular wall. So when you're operating in this region, this is the region where you avoid retraction, because even a small injury will cause damage and you will have some hemiplegia. So this is the most important aspect when you are performing surgeries in the region of the foramen of Monro. So this was the world's largest experience of colloid cyst at the time, published in 2002 by our department, by Professor Goel. We had a series of 105 cases. Now we have many more, and I still believe that it is the largest series. And we approach all these tumors by the transcallosal approach. We do not prefer a transcortical approach, again for the same reasons that the minimum neural injury is by a transcallosal approach rather than a transcortical approach. So here you can see the colloid cyst. Here you can see how small that callosal incision is to enter, and this is the post-operative scan showing removal of the colloid cyst. So what are your landmarks to enter here? Again, as I said, your craniotomy will be 2/3 anterior to the coronal suture and 1/3 posterior to the coronal suture. And you will retract in this region to enter the interhemispheric fissure. So these are intraoperative photos. Here, you can see the craniotomy. Here you can see that the medial aspect of the cerebral hemisphere is being retracted here. It is retracted here. You can see both the pericallosal arteries and the region of the corpus callosum here. The corpus callosal incision has been made, and you can see into the ventricle now. So as soon as you make the callosal incision, the CSF will come out and the brain will become lax in case it is tense. So here you can see the relations that you see intraoperatively. So this is your region of the foramen Monro. You can see here the colloid cyst projecting into the region of the foramen Monro. Here you can see the choroid plexus as it is entering the foramen of Monro. So how do you identify which side of ventricle you have entered? Suppose you enter into the ventricle. Sometimes you may enter the right side, sometimes you may enter the left side. So the most important landmark here is the choroid plexus. So if your ventricle, if your foramen of Monro is medial to the choroid plexus and the thalamostriate vein is lateral to it, then you have entered the right ventricle. And if your thalamostriate vein is more further to the left, then you have entered the left ventricle. So this is how the colloid cyst is being removed. You can see here the choroid plexus, how it is draped over the region of the colloid cyst as it is lying in the region of the foramen of Monro. And this is after excision of the colloid cyst. And this is the entire foramen of Monro, which if you enter inside, you will straight into the third ventricle. So this is an interesting case. Sometimes you enter the ventricle and you don't see anything. You enter the right side, you enter the left side, you don't see anything. But your scan shows a colloid cyst. So where is the colloid cyst? The colloid cyst lies in the region of your septum pellucidum. These are rare cases. And here you can see in this MRI image, you can see these two leaves here. Here it is seen more clearly. These are the two leaves of the septum pellucidum, and the colloid cyst lies in this region. So you can puncture the septum pellucidum and identify the colloid cyst and then remove it. So nowadays, a lot of endoscopic approach has been advocated for colloid cyst surgery. There are people who are performing endoscopic surgery, but we still believe that the transcallosal approach and a small craniotomy is the best way to go to remove these tumors. So we have seen most of the portions of the lateral ventricle. Now let's come to the temporal horn, which lies in the inferior aspect of the temporal lobe. So here you have the temporal horns on both the hemispheres. This is your splenium of the corpus callosum. This is your region of the atrium. Here again you can see the bulb that is formed in the middle wall of the atrium by the splenium of the corpus callosum. So here in the temporal horn, you have the medial part is formed by the hippocampus or the hippocampal formation. So here you have the hippocampus. Above it you have the fimbria, which is turning and forming the crura of the fornix, the body of the fornix, where they come together and going down as the columns of the fornix to end in the mammillary body. This empty space here is actually occupied by the hippocampal commissure. It is stuck to the splenium. It is difficult to separate both these regions, the splenium and the hippocampal commissure. And if you try to separate it, you will more likely damage the hippocampal commissure. So there's a lateral aspect again showing the lie of the hippocampus in the temporal horn. So you can see here, this is the temporal horn. This is the medial aspect of the floor of the temporal horn where the hippocampus lies. This is the beginning of the fimbria as it goes on to form the fornix. Now let's see the temporal horn from both a medial aspect and from a lateral aspect. So when you come from the medial aspect, this is your parahippocampal gyrus. We have seen this last time, so I'm going to go a bit fast in this. So this is the region of your parahippocampal gyrus as it turns to form the uncus. This is your region of the hippocampal head. So the parahippocampal gyrus, as we have seen, continues here as the cingulate gyrus, and also part of the lingual gyrus ends in the parahippocampal gyrus. When you remove the parahippocampal gyrus, this is the radiation of the cingulum as it is ending down in the region of the entorhinal area. This is the hippocampal head. This is your dentate gyrus, and this is your fimbria. So this is your dentate gyrus as it is going above. It goes above the corpus callosum to form the subsplenial gyrus and then continues as the indusium graecium. And here you have the fimbria of the fornix going above and forming the fornix. This we saw last time are components of the limbic system, the mammillary body, mammillothalamic tract, and the anterior nucleus of the thalamus. So again, here you can see the whole fimbria, the hippocampus head, the fimbria, and the fornix as it is curving around the thalamus. So this region here is your choroidal fissure, and I will show you more images of this so we can understand it completely. So now we saw it from your medial aspect, the temporal horn. This is from the inferior aspect. This is your parahippocampal gyrus. When you remove the gray matter of the parahippocampal gyrus, you start seeing the end of the cingulum, the radiation of the cingulum as it ends here just below the ependyma of the temporal horn. So here you see the radiation of the cingulum. This is just the beginning of the ependyma of the temporal horn. You remove the cingulum fibers and you can see the ependyma of the temporal horn clearly. You remove the ependyma and you will see the hippocampus in all its glory. So this is your temporal horn. This is from your inferior aspect. So the middle aspect is the hippocampus. This is your lateral part of the temporal horn, and above it is the roof. Here you have the amygdaloid nucleus in the roof of the temporal horn, and this is the choroid plexus in the choroid fissure. So once you deflect the hippocampus and the choroid fissure, you start see the beginning of Mayer's loop. So you see the optic tract, which is ending in the region of the lateral geniculate body. And you can see fibers that are starting here and going all the way in the lateral aspect of the temporal horn, forming the Mayer's loop. So this is from your inferior aspect. This is again, I've turned the specimen. So you can see the Mayer's loop as it is coming and curving and going in the lateral part of the temporal horn. And when you see from a lateral aspect, again, you see the Mayer's loop here. So this is your area of the temporal horn. And the Mayer's loop as they curve and form the roof, and posteriorly they form the lateral wall of the temporal horn of the ventricle. And they also cover the lateral part of the atrium of the lateral ventricle. So we saw from the medial, we saw from inferior, now we are seeing from the lateral aspect. So when you go from the middle temporal gyrus, here you have the hippocampus, you have the head of the hippocampus, body of the hippocampus, and the tail of the hippocampus lying in the temporal horn. This is a coronal section showing that the medial aspect of the temporal horn is formed by the hippocampus. The lateral part of it is formed by the eminence of the collateral sulcus into the ventricle, that is called the collateral trigone or the collateral eminence. In the roof and the lateral wall, you will have the optic radiations and the fibers of the tapetum. As you can see here, these are the fibers of the optic radiations along with the IFOF covering the temporal horn. So you don't see the temporal horn unless you turn the specimen slightly. And now you can see it here very nicely. This is the hippocampus. This is your temporal horn ependyma. So the fibers are coming and turning here in the roof and then going on to form the lateral aspect of the temporal horn here. So you have fibers of the optic radiation, mainly Mayer's loop in this region. And you see this region that is devoid of any fibers, which is safe to enter into the temporal horn while performing surgery in this region. So this is the relation of the hippocampus to the whole internal capsule. Here you can see the internal capsule, anterior limb, the genu, the posterior limb, the sublenticular form and the retrolenticular portion of the internal capsule as they go into the cerebral peduncle. This is your hippocampus, which has been pushed down. Here there is an area here where there is no fiber and you can straight enter, and the optic radiations as they go on to form the lateral part of the temporal horn and the atrium of the lateral ventricle. So this approach for the first time in the literature was discussed for epilepsy surgery by Professor Goel. We entered for an amygdalohippocampectomy. So we performed a temporal lobectomy along with an amygdalohippocampectomy by making a corticectomy in the middle temporal gyrus. So this is a simulated cadaveric specimen showing the approach. So this is your region of your middle temporal gyrus where a corticectomy has been made. So you start seeing the hippocampus in this region. This is the tail. So basically when we perform the surgery, this is our landmark that we transect the hippocampus where the body turns into the tail. So here again another specimen. So this is the whole region, the region of the hippocampus where it is turning into the tail, the head and the amygdala. So all of this region along with the neocortex is removed and performing a temporal lobectomy along with an amygdalohippocampectomy till you see the pia on the surface, middle cranial fossa floor. So again, this is a specimen where I told you, see, there is a region here. You can see this pinhead here. There is a region here where there are no fibers. So it is very safe to approach this region and perform a temporal lobectomy along with amygdalohippocampectomy in this region without causing any damage to the patient. So this is a case of a intraventricular epidermoid in the region of the temporal horn. So you can see this image. This is your thalamus, which has been pushed. So basically it is in the choroid fissure and it is entering into the temporal horn here. And you can see here in the diffusion completely occupying the temporal horn. These are the post-operative images. And this is your intraoperative image after resection of the tumor. Here you can see the hippocampus head. Here you can see the body of the hippocampus. This is your region of the amygdala. And this is your region of the choroid fissure. This is your inferior choroidal point as the anterior choroidal artery enters at the junction of the head and the body of the hippocampus. So this is your choroidal fissure. If you enter into this region, in this choroidal fissure, you can straight enter the ambient cistern. and the crural cisterns. So this is one approach to these cisterns. So now we've seen most of the parts of the lateral ventricle, and then you have the major part of a lateral ventricle, that is your choroidal fissure. Now it is very important to understand what this choroidal fissure is. It is basically a C-shaped cavity. It is a C-shaped structure that runs all the way from the foramen of Monro to the temporal horn between the fornix and the thalamus. So this is one hemisphere. This hemisphere has been cut here. Here you can see the fornix and the thalamus. So this is your region. This side fornix has been removed. And you can see this choroid plexus that is running here, right in between the fornix. So here you have the fimbria of the fornix, and this is your region of the thalamus. So this is the cleft that is present between the fornix and the thalamus, and it is C-shaped, running throughout, occupying a majority of the ventricle, and within it runs your choroid plexus. So this is another image that is showing the choroid plexus and the choroidal fissure. So you can see the head of the hippocampus. This is your choroidal plexus, inferior choroidal point as the anterior branch of the anterior choroidal artery enters to form the choroid plexus, going into the atrium, forming the glomus, forming a tuft of choroid plexus, and then running into the body of the lateral ventricle. This is again your insular relations to the ventricle, showing the landmarks, your anterior insular point pointing towards the caudate, your posterior insular point pointing towards the atrium, your long gyri which are part of pointing towards your body of the ventricle, and your short gyri of the insula which are pointing to the frontal horn. So this is an image from the top, and you can see beautifully the choroid fissure here, choroidal fissure. So here you have the fornix. You can see this here. I hope you can appreciate this. This is your fornix that is running all the way to the temporal horn here. Just lateral to it is your thalamus here. And this cleft between your thalamus and the fornix, this is your choroidal fissure as it runs along the whole of the lateral ventricle. This is your region of your caudate nucleus, and this is your striothalamic sulcus, in which runs the thalamostriate vein and the stria terminalis. The stria terminalis so runs along here at the inferior margin of the thalamus and goes all the way here to end in the roof of the temporal horn, as in the part of to end in the amygdala, which is present in the roof of the temporal horn. So basically, when you enter the choroidal fissure in this region, from here if you enter, you will enter the third ventricle. If you enter into the atrium, if you open the choroidal fissure and enter here, you will come in this region, that is your region of your quadrigeminal cistern and your pineal region. And if you enter from the temporal side, if you enter the choroidal fissure from the temporal side, you can approach the crural cistern and the ambient cistern. So the choroidal fissure, the choroid plexus around the choroidal fissure is attached to both the thalamic part and to the fornicial part. So when it is attached to the fornicial part, it is called tinea fornicis, and where it is attached to the thalamic part, it is called tinea thalami. So traditionally, it is safer to transect the choroid plexus between the tinea fornicis and the choroid plexus, not on the thalamic side, but on the fornicial side. So again, this is another image showing the choroidal fissure beautifully. Here, one layer of the corpus callosal fibers I have preserved here. This is your fornix. This is your foramen of Monro in this region. This is your choroid plexus as it is entering into the choroidal fissure. This is your region of your thalamus, and this is your region of the fornix, just beneath the corpus callosum. As you will see here, now that one thin layer of the corpus callosum I have removed. So you can see the fornix on this side, the fornix on this side, and if you enter the choroidal fissure here, here you have the cavity of the roof of the third ventricle. So this is one approach to the third ventricle through the interfornicial region. So this is both your fornices, and this is how you can enter the third ventricle. And this is again your choroidal fissure, and this is the region of your atrium. So these are some interesting cases that we had. We have finished discussing most of the lateral ventricle anatomy. Just before I go to the third ventricle, this is an interesting case that we had. This young patient came to us with severe headache and vomiting. This was the initial CT scan that we did on him. And you can see this lesion here in the region of the foramen of Monro. Before we could do an MRI or before we could operate on him, he suddenly worsened and developed eye movement problems. So we did an MRI, and we saw that the cyst had migrated to the third ventricle, to the posterior part of the third ventricle, and he developed eye movement disturbances. Within the MRI, when the MRI was going on, this tumor again shifted and came to the fourth ventricle, to the inferior part of the fourth ventricle. And this is finally when we operated the patient, and you can see that it was a neurocysticercosis cyst, and we removed the tumor here. Another interesting case of a choroid plexus papilloma, when the patient presented to us as a child, the tumor was in the atrium of the lateral ventricle. It was probably hanging by the choroid plexus stalk. A shunt was performed on him. Then the tumor migrated near the frontal horn. And then before we operated on him, the tumor was actually in the body of the lateral ventricle. So these are a few interesting cases of the lateral ventricle. And we finished the anatomy and the approaches of the lateral ventricle. Now let's go to the other important one, that is the third ventricle, which is even more inaccessible than your lateral ventricle because it is right in the region between the thalami in the central aspect of the brain. So your third ventricle lies above the region of your circle of Willis, your pituitary stalk, the sella turcica, and above the brainstem in this region. So you can see here it has an anterior wall, it has a floor, it has a posterior wall, and it has a roof. So the anterior wall of the third ventricle is formed by structures that are, some structures are seen on this image, some cannot be seen till you transect this. So the anterior part has part of the fornices as part of its anterior wall. Then you have the anterior commissure, then you have the lamina terminalis, and then you have the superior portion of the optic chiasm. The floor of the third ventricle is formed by the optic chiasm with the optic recess, the infundibulum with the infundibular recess, the median eminence in this region, the tuber cinereum, the mammillary body. Then you have region of the tegmentum that lies above the cerebral peduncle and the aqueduct. And then you have come to the posterior. You're in this region before you have posterior perforated substance and the aqueduct. So this is your floor of the third ventricle. So an interesting thing is half of the floor of the third ventricle. So this portion of the floor of the third ventricle is formed by dancephalic structures. And this portion of the floor of the third ventricle is formed by mesencephalic structures. This is the lamina terminalis, as I told you before, as the hemisphere turned and the membrane came all the way inside. So this was your original end point of your hemisphere. And that is why it is called the lamina terminalis. This is your region of the roof of the third ventricle. The posterior part of the posterior wall of the third ventricle is formed by a series of recesses and commissures. So you have the pineal gland here. A recess above the pineal is your suprapineal recess. Then within the pineal, upper and lower lamina of the pineal, you have the pineal recess. Then you have the posterior commissure in this region and the habenular commissure above the pineal gland. The habenular commissure actually connects two habenular nuclei. So habenular nuclei are actually part of the epithalamus. So if you see this structure here, this is your striae medullaris thalami that connects your septal nuclei, which we have seen earlier in the limbic system. This is your region of the septal nuclei. It connects all the way with the striae medullaris thalami to the habenular nuclei here in this region. And the habenular nuclei of both sides decussate and form the habenular commissure. And from there, the fibers go down to the floor of the fourth ventricle in the salivatory nucleus. So basically, your sense of olfaction is conveyed by this tract by the habenular nuclei to the salivatory nucleus in the fourth ventricle. So your striae medullaris thalami. This is your interthalamic adhesion. This portion of the lateral part of the wall of the third ventricle is your thalamus, and the inferior portion is your hypothalamus. So now let's go to the roof of the third ventricle. So we saw the anterior wall, the inferior wall, the floor, the posterior wall. Now we have a roof. The roof of the fourth ventricle, or a third ventricle, is formed by four structures basically. So you have the fornix here. This is the region of the fornix. Then you have the tila choroida in this region. There are two layers of the tila choroida. Within these two layers, you have some vessels that are the internal cerebral veins and the medial posterior choroidal artery. So these are the four layers that form the roof of the fourth ventricle. The roof of the fourth ventricle, between the two layers of the tela, there is a space, and this space is called the velum interpositum. The velum interpositum enters sometime into the quadrigeminal cistern. It opens. Normally there is a layer here and it is closed, but sometimes it opens into the quadrigeminal cistern, and it is called the cistern of the velum interpositum. And sometimes, rarely, there is a space between the hippocampal commissure and the velum interpositum, and that region is called the cavum Burgei. So now you see this is the roof of the third ventricle. So here the splenium has been cut. This is the region of the fornix, and just beneath here you have the tela choroida. This is your region where the hippocampal commissure will be there once you have the splenium over this region. So now this is an anterior inferior region of the third ventricle. So here you see the anterior commissure which forms the anterior wall. So this will be your region of your lamina terminalis which has been removed here. Here you can see the interventricular foramen of Monro and the columns of fornix. And just beneath this region here, you will enter into the third ventricle. So these are the structures that form, when you see from the inferior aspect, these are the structures that form the floor of the third ventricle. You have the optic chiasm, the infundibulum, the tuber cinereum, the mammillary body, and posterior perforated substance, and region of the cerebral peduncle, tegmentum above the cerebral peduncle, and the aqueduct. So once you cut this, you will be able to see the roof of the third ventricle. So here you can see that the cut has been made here between both the mammillary bodies, and you can start seeing the roof of the third ventricle in this region. Here, this structure here that is connecting, you can see, is the anterior commissure. And more posteriorly, as you see the vessels and the tela choroida as they form the roof of the third ventricle in this region. This has been cut, the midbrain has been cut, and you can see the roof of the third ventricle. So another interesting thing that I forgot to tell you about the tela choroida is it has two layers. It has an upper lamina and it has a lower lamina. So the upper lamina attaches to the lower portion of the fornix, and the lower lamina comes and attaches to the pineal. And the recess between the pineal and this lower lamina is your suprapineal recess. So going further, now we've seen most of the anatomy of the third ventricle. How do we approach lesions in the region of the third ventricle? So this is a case of you can see the fornix here, the corpus callosum here. This is an unusual case of a colloid cyst in the region of the velum interpositum that we have approached through an interfornicial approach. So a transcallosal interfornicial approach, as we saw in the cadaveric specimen, and the tumor is removed by this interfornicial approach. This is another tumor that is in the region of the center of the thalamus or in the region of your massa intermedia, again approached by an transcallosal interfornicial approach. Basically, there is a transchoroidal approach, a subfornicial approach, and an interfornicial approach. So we have approached both these tumors by the interfornicial approach. This is one tumor. This is another tumor, similar tumor in the anterior portion of the third ventricle, which was approached by an interfornicial approach. So you can see the anatomical correlates of this approach here. These are both the fornices. This is your thalamus, and this is the region of your third ventricle. So when you enter transcallosal, you have a dilated foramen of Monro and you can enter from there, or you come posteriorly and the columns of the fornix are splayed and you can enter the third ventricle from that region. So that is to approach tumors in the anterior aspect of the third ventricle. When you have tumors in the posterior aspect of the third ventricle, you either have an occipital transtentorial approach, which you can use if your tumor is basically above the galenic venous system, and you have a supracerebellar infratentorial approach, which we mainly use when the tumor is below the galenic system. So here you can see the posterior part of the third ventricle. When you see from this approach, the only structure that you see in the posterior aspect of the third ventricle is basically your pineal body here. So this is when you go from a supracerebellar approach. So this is the intraoperative images. You can see the craniotomy. Here, this is an epidermoid in the region of the pineal, posterior third ventricular region. So the cerebellum has been retracted here, and you can see that thick arachnoid has been removed, and you can see this epidermoid here elegantly. And this is after the epidermoid has been removed. And this portion here is your posterior part of the third ventricle. So it is not communicating here. and there is a arachnoid covering it, and this is your region of your brainstem, and this is the, after tumor excision, the supracerebellar avenue to approach the posterior third ventricle. This is another tumor in the region of the posterior third ventricle. You can see the posterior part of the roof of the third ventricle, posterior part of the third ventricle has been pushed. This is the post-operative image. Now I'd like to show you some intraoperative photos. So this is your supracerebellar region, and we have entered here. So here the third ventricle has been entered. The posterior part of the third ventricle has been entered, and you can see the choroid plexus in the roof of the third ventricle. Here you can see the choroid plexus hangs down from the roof of the third ventricle, and you can see this in this region. This is your region of your posterior commissure. Once you go inside, this structure here is connecting both the thalami, and this is your massa intermedia or your interthalamic adhesion. So this is when you are seeing the ventricle from a posterior aspect. So this is your interthalamic adhesion, and this is the choroid plexus in the roof of the third ventricle. And when you lift the massa intermedia, here you can see both the foramen of Monro and the columns of the fornix as they're forming the anterior portion of the wall of the third ventricle. So you are seeing the third ventricle completely from a posterior aspect, and this is the anatomy of the region. So this is another tumor in the region of the posterior third ventricle, which has been removed by the supracerebellar infratentorial approach, and you can see the post-operative image. This is the vein of Galen that has been completely preserved. So this is the anatomy of the lateral and the third ventricle. I hope you have understood. Thank you very much.
Hello, Abhi. This has been a wonderful lecture. John Bennett had some problems with internet connection, so
Okay.
now I am the amphitryon.
Okay.
So let me read from Harshad Parekh.
Yes.
He said that excellent, fascinating dissection of brain and ventricles. Great explanation for various approaches to ventricles. Thanks a lot, Dr. Abid. So I agree with him. This was a really wonderful lecture. You show us very good dissections, different cuts in the same brain. So that is really good to understand the 3D anatomical structure of our brain. So I like if anybody have some questions, please, or if anybody has some comment, please. I agree also with Harshad Parekh. You show us not only anatomy, but also very nice surgical approach to all the ventricles, lateral, third ventricle. So I enjoyed a lot this lecture. So I think John Bennett has come back.
Well, I don't know, Abby. Victor's taken over my job. I just leave the webcast for a minute and he takes over.
Your job is in demand, John.
Well, I was working on the Kahoot. I've got the Kahoot finished. So we can do that whenever you're ready.
Okay.
Now, I don't know if there's any more comments or questions from the panelists. Does anybody want to check in with Abby about her talk? Any comments? If not, let me just go ahead to the Kahoot now. Now the Kahoot is basically a platform which is it's self-explanatory when you see it. It's a game we're going to play, multiple choice, and you're going to need a smartphone to play. Basically, go to the smartphone and go to kahoot.it. Okay, and I'm going to show you right now. I'm going to show you the, okay, I'm going to screen share it and we'll take you through the steps you got to do. Okay, let me share the screen here. Okay,
Hello.
now here's a Kahoot's interface. I'm going to put play lateral ventricles. Okay. Okay, now it's generating a pin. Okay. That pin is a pin that you put that number on your smartphone. You go to kahoot.it, just like here. You got that, Victor? Kahoot.it on your smartphone, and then put in that pin. And you'll come up here as you come in. Okay, Victor, I expect you to get in too. And we're going to need you, Victor, because Abby made a tough test. And you're going to see these questions aren't easy.
I didn't make it. I'm telling you.
Oh, really? They were tough. I'm going to be surprised if anyone does well on this test. It's a tough one.
Yeah, it's a tough one. I
Yeah,
agree. It's a tough one.
Yeah. Okay, we got 4 people in here, so people are understanding what we're doing.
Yeah. John, I would say you increase the time for them to read the question. Otherwise, maybe give more time.
Yeah, we can do that. We can artificially just wait till people are.
Yeah.
Okay, we have a good turnout here. I think people, Abby, people are going to learn this platform, and I think we're going to get better as far as using it. And I hope. Okay, I'm gonna wait till I get in here. We got a good turnout here.
Yeah.
Okay, and this is going to be a very useful platform, especially involving neuroanatomy. Okay, let me check in myself here. You're going to see me check in a second. First, I'm going to kahoot.it. And take your time. Okay, I'm going to log into Kahoot also. The number is 357-8902 to enter the interface. And once you come to the interface, I'm gonna punch in that pin right now. 357 8902. Okay. I'm connected. My nickname is Crazy Tiger. You're gonna see me come in. Jolly Cheetah. We're gonna have a good turnout here. Okay, I'm in. Okay, Jolly Cheetah. 1, 2, 3, 4. Okay, we have a good turnout. Okay, we're gonna start. And you answer the questions on your smartphone, A, B, C, or D. And like Abby suggested, we'll try to take our time. Okay, I spelled a lot of ventricles wrong. I'm going to fail this test. Okay, which relation is true regarding posterior wall of third ventricle? Okay, it's a tough question, Abby. So it wasn't you. Who put this question together?
I'm not going to tell you, but it wasn't me.
Dr. Goel.
No, no, not him.
Okay. Okay. We only had one answer. Is that correct? I don't know if what happened there. Okay. I'm showing the answer. Okay. Whatever. Okay. Why aren't we getting answers here? Something's wrong. End game. Okay. That can't be right because you time's up. Okay, we'll figure this out.
Okay.
We'll figure this out. Show media. What does that mean? Okay, we'll try. I'm sorry about that. We'll try the next question.
Oops.
School board. Okay, next. Which of the following statements is not true?
Just give them time. They'll be able to answer it.
Okay. It kind of stops on its own.
Okay.
And then let me see if I can prevent the next screen from coming up. Oh, so we did get some answers. Okay, good.
Yes, yeah, that's the right one. The yellow one is the right one.
Okay.
Yeah.
Yeah, I guess we can go over them now, Abby, if
Go
you
slow
want.
because then they'll get it.
Okay, most people got it, huh?
Yeah.
Okay. Any comments, or is it pretty straightforward?
No, this one's pretty straightforward.
Okay, let me go to the next question. Okay, tally the scores. Epic New forges to the lead. Okay. Choroidal fissure is the body of the lateral ventricle lies between.
Choroidal fissure in the body of the lateral ventricle lies between.
Okay, there's I believe A is laterally, the last word.
Yeah, yeah.
Okay, what do you think there, Abby?
Yeah.
The right answer is C. Okay, one person got it right with the. Okay. Next question.
Glowing seal.
Okay, nobody got that one right. Okay. Which of the following is not correct? Sure. These are long questions, Abby. Sure they don't have time.
That's what I said. They need time because it takes time to read it.
Yeah. Yeah. Yeah,
So you have an answer.
unfortunately, I can't stop it. Okay, this is the correct answer. One person got it right. 4 people got it wrong. Why did so many people got that wrong, Abby? Is it similar?
No.
Tapetum separates the fibers of optic radiation from the temporal horn. Okay, most people answered that. Okay, let's go on to the next. Oh, epic bison forges ahead. Can you feel the excitement, Abby? I feel excitement in the air.
Uh-oh.
Which of the following relation in the atrium is not correct?
This one's easy.
Okay, what do you say, Abby? It's a tough question. That's a tough one.
No, this is easy.
Okay, none of the above. That's a trick question. That's a tough one. Okay, most people got it wrong. Okay, Balanced Wolf takes the lead. Stria medullaris thalami connects which 2 of those structures? I think people should get this.
Yeah.
Okay, most did get it right. Right, Abby?
Yeah.
Good. Okay. Epic bison comes back in the lead. Okay, which of the following doesn't take part in the choroid plexus? It's getting tense. We're getting down to the wire. It's nail biting time. Okay. Oh, that's great. Everyone did good on that. We're getting better. Okay, how did Epic Bison do on that one? Epic Bison get that one right? Okay, Epic Bison's still in the lead. 3 answers in a row, Balance. Wolf. Which of the following is not true in relation to the roof of the ventricle? That's another tough one.
That's easy.
Okay. 3. Okay. Okay. Good. The most got it right. Okay. Fornix, Bellum, Deposa. Okay. Let's see how many. Oh, Balanced Wolf takes the lead from Epic Bison with 2 more questions to go. Okay. We'll see who takes the crown. Okay. Which of the following is not true about Vellum? Okay. B. Well, two out of 5 got it right. It's not true. That's a tough one too. Oh my God! Epic Bison gets back in the lead. It comes down to the last question. Okay. There it is for all the marbles.
This one's easy.
Which relation is true for floor of third ventricle? It's a good question. Okay. We got some answers. Okay. All right. We finished off great. Now, can I have a drum roll? I'll have to get a drum roll on the audio the next time.
Okay.
Okay, we'll see who takes the crown. This is for number 3 position. And number 2, 5 out of 10. Number 1, Epic Bison. Okay, with a real Epic Bison, please step forward. Is it you, Victor? Okay.
No, it's not me. No.
It's got to be Abby.
It's not
No, I didn't play it.
Oh, you didn't play it? I didn't either because I would get too many wrong answers. Okay.
All right.
Okay, fess up, everybody. Who is Epic Bison?
Here. Dr. Neha Jadhav.
Oh, okay. I don't see the name there. Did he say?
In the chat.
Okay, let me get the chat here. Okay, let me get the chat. Okay, well, you want to introduce yourself, Naha? You don't have to if you don't want to, but you can say hello if you like. Okay, well, I guess does not want to do. That's okay. Okay, well, we have a question here, Abby. Dr. Abhinav asks, can we please see any intraoperative image from the transfornicele approach? Would you have that, Abby?
No, I don't have that one.
You have that? Okay, unfortunately. Okay. Okay, maybe you can write Abhinav and write Abby and ask for it. if you want to just put it in the chat, if you want to get in touch with Abby for any reason, right, Abby? If any,
Yeah.
okay. Okay, very good. Well, be honest, Abby. Did you enjoy that? Were you on the edge of your seat for that quiz?
I knew the answers.
No, it was tough, wasn't it?
Yeah, it was tough.
Well, I can imagine if you're in an exam and you're in a hurry,
Yeah,
some of those long questions would be tough. They
yeah,
would slow you down.
yeah,
Best to skip that and go to the short ones. But we'll get better. And like when you have short questions, it's a lot better.
yeah.
And so, okay, Victor, where were you, Victor? Were you Epic Bison? Who were you?
I don't know.
Oh, you don't want to say, huh? I know it was tough. It was tough. It was a tough one. So, okay, very good, very good. So, Abby, when are you scheduled to your next?
I'm not sure.
In a couple of weeks. Oh, you don't have to say.
I'm
Okay.
not sure.
Okay, very good, Abby. Thank you very much.
Yeah.
And we're going to end this. We're going to try something innovative. We're going to end the broadcast, and we're going to show you after the broadcast ends. I take it off YouTube. I take it off the internet. Abby's going to take us on a tour of her sumptuous studio off the air, so she won't have to worry about being taped and being used in court or whatever. So I'm going to end this broadcast now. So thanks, everybody. And just everybody in the panel, stay here. We're going to talk to Abby. We're going to talk to Abby and Victor and others. Okay. Okay. So, okay, let me just stop the broadcast.